Hi, everyone. Welcome. Thank you so much for joining us today for our webinar, What's New in the 2024 U.S. Medical Eligibility Criteria for Contraceptive Use, U.S. MEC, Selected Practice Recommendations for Contraceptive Use, U.S. SPR, and Quality Family Planning Guidelines. We hope you are all doing well and staying safe. My name is Nicole Nguyen, Program Manager of the Family Planning Program at the California Prevention Training Center, the CAPTC, under contract with the California Department of Healthcare Services Office of Family Planning is sponsoring today's event. So welcome. And before we get started, I'd just like to go over some quick housekeeping slides. So for our new updated dashboard, so the top right ribbon on your screen is the control panel. And then you'll see the question icon. This is where it controls where you can submit comments and questions. There is a little paperclip icons that controls where you can access any handouts that will be attached for this presentation. There's also a setting icons. This controls your audio connection preference. And then the 3-dot is how you can switch to full screen mode. And then also to check your audio, please click on the settings icon, and from there you can check to your desired setting to join either through your computer or to call in through your phone. And if your internet connection is a bit shaky, we highly recommend that you call in through your phone for the best possible sound. And then please use the questions icon to submit any questions and comments for the presenters throughout this webinar. This webinar will be about 90 minutes and include time at the end for the presenters to answer all your questions. So continue to send them in throughout the presentation, and our speakers will address as many of them as possible at the very end. This webinar will be recorded, and we will send out a follow-up email with the recording and the slide deck. There is an evaluation at the end, so please make sure you take the time to fill that out because your feedback is really important and really help guide us in developing our future content. And then before I introduce our presenters, I want to acknowledge that we are working with the University of Nevada, Reno School of Medicine to provide CMEs for this event. This webinar qualifies for 1.5 CME credits and only available to those who watched the entire webinar live today. Those who watch the recording afterward will not be eligible for any CME credits, and the link to access your CME certificate will be included in the follow-up email to those who attended today, along with the recording, the slides, and the evaluation. And then, of course, for transparency, we want to state that all presenters, planners, or anyone in the position to control the content of this continuing medical education activity have indicated that neither they nor their spouse or legally recognized domestic partner has any financial relationship with commercial interests related to the content of this activity. Okay, so now I get to introduce our awesome presenters. We have two joining us today. So first we have Dr. Michael Polakar, who is Professor Emeritus of Obstetrics, Gynecology, and Reproductive Sciences at the University of California, San Francisco School of Medicine. And he's the owner of Polakar Lectures, a reproductive health policy consulting company in San Rafael, California. Since 2015, he has been a clinical fellow for the National Family Planning and Reproductive Health Association, NEFRA, in which he advises staff regarding clinical and health policy issues regarding the Title X, the Federal Family Planning Program. He is also a senior medical advisor to the California State Office of Family Planning through a contract with the California Prevention Training Center in San Francisco, California. He is a widely known speaker with an interest in health delivery system and women's health issues, including family planning, cervical cancer screening and management of precancers, health screening, menopause, female genital tract infections, and genital skin condition. And he is the senior author of the textbook Contraceptive Technology. The most recent edition is the 22nd revised edition that came out in 2024, and the chapter author of Screening for Cervical, Ovarian, and Breast Cancer. He has served on multiple expert advisory panels for the Center of Disease Control that resulted in the publication of the U.S. MEC for contraceptive use in 2012, 2016, and 2024. The selected practice recommendations for contraceptive use, and providing quality family planning services recommendations of CDC and the U.S. Office of Population Affairs in 2014. And we're so happy to have him present with us today. And then our second amazing presenter is Dr. Jennifer Carlin. She is an associate professor in the Department of Family and Community Medicine at the University of California, San Francisco, with fellowship training in family planning and clinical medical ethics and a PhD in anthropology and history of medicine. Dr. Carlin is a researcher and full-scope family physician who sees patients in urgent care and Planned Parenthood. Jennifer serves as an advisory role as the new medical consultant for the California Prevention Training Center and the Family Pack program, a role that was previously with Mike, and now she has taken that on. So we're super excited to introduce her as our new medical consultant. And she also is an associate editor for the Annals of Family Planning and sits on the Grantee Clinical Leadership Advisory Council for the Clinical Training Center for Sexual and Reproductive Health. Thank you so much for you both for joining us today. And with that, the floor is yours. So
Okay.
let me
Great.
get that control to Mike.
There we go. And Nicole, be sure to allow me to be able to advance the slides.
Yes, go ahead. You should be able to do it now.
There we go. Take remote control. I'll be able to do that, I hope. Okay, great. Well, thank you all so much for joining us. We've been working on this for months and months to get it ready to go. And before we jump in and start talking about these guidelines, what I want to do is tell you a little bit about why they're so important in Family Pack. And that is since the beginning of the Family Pack program in 1996. Of course, this program goes back even earlier when we were state-only family planning. But since 1996, really a high priority of the California Office of Family Planning has been this expectation of providing high-quality, evidence-based care to Family Pack clients. And one of the ways that we do that is we've integrated into the Family Pack standards the expectations that clinicians seeing Family Pack clients are going to be following a couple of national benchmark clinical practice guidelines. Now, two of those are the ones that we're talking about today, the medical eligibility criteria and the selected practice recommendations. There's also reference to the quality family planning guidelines, which we will also discuss today, and a number of other guidelines, for example, the 2021 CDC STD treatment guidelines. So there is an expectation that as you see Family Pack patients, and of course this would apply to your other patients as well, that you're going to use these evidence-based tools as you provide care to your clients. And just one other thing to mention very quickly is that Family Pack also offers lots of other guidance that comes from these guidelines. For example, our clinical practice alerts, of which now I think we're up to 15 or 18 of them, the whole library of webinars that we put together, and we'll be referencing a few of those today as well. The information which is in the PPBI, the policies, procedures, and billing instructions for Family Pack, and there are also lots of links to other national guidelines. So it's not only what we talk about right now, but all of the other resources that are available to you on familypack.org. So with that, I am going to try to, oh, there we go. I'm looking into how to advance here. Okay, good. So you know about us. We've already done our introductions and our disclosures. Okay, and here is our agenda. We're going to talk about the updated sections of the 2024 Quality Family Planning Guidelines. That's one that you may not know as much about in comparison to the MEC and the SPR. Then for those of you who are kind of new to this particular topic, we'll talk about some of the conventions used with the safety categorization system, which is used in the medical eligibility criteria, various categories that actually originated with the World Health Organization and are now used in the medical eligibility criteria. There's a whole suite of resources that are available for implementing the medical eligibility criteria and selected practice recommendations from the CDC. I'll tell you a little bit about what they are and how to get them. And then Jen is going to cover specifically what the updates and modifications are in the 2024 version of the MEC and the SPR. The new conditions that are covered, particularly chronic kidney disease and sickle cell disease, but also how some of the safety classifications actually changed with numbers going up or numbers going down in this version of the MEC. Then we'll wrap it up and take your questions after that. Okay, so now just a quick review about the National Family Planning Guidelines that we all should be using. And I love this graphic because it looks at a whole suite of family planning recommendations that are available mainly from the Centers for Disease Control, but from other sources as well. So first off, if you look over at 9 o'clock where it says contraception guidelines, that includes the two guidelines that we're going to be talking about this afternoon, the medical eligibility criteria and the selected practice recommendations. Down at 6 o'clock, you see other guidelines that are recommended by the Office of Family Planning, and that is the CDC STI treatment guidelines. And by the way, that badge is a little old. It says 2015. Of course, we now work with the 2021 CDC STI treatment guidelines. And the red ribbon, of course, refers to the HIV guidelines, which come from the CDC. Over at 3 o'clock are what used to be called the preconception guidelines. Nowadays, they're called the pre-pregnancy guidelines that also come from the CDC. And up at the top at 12 o'clock are the guidelines for, number one, helping people to achieve pregnancy when they want to, and then also information about how to do infertility evaluations for both females and males. The CDC doesn't have guidelines on that, but instead we use the guidelines from the ASRM, which stands for the American Society for Reproductive Medicine. But basically, all of these are an integrated suite of guidelines that really cover virtually everything that we do in the world of family planning. Oops, now, I need to try to go back. Nicole, I don't know if you can do that. Oh, hang on a second. Maybe I can go back. Just a second. Okay, so here we are with QFP. So the Quality Family Planning Guidelines were first published in 2014, and they were a collaboration of the Office of Population Affairs, which runs the Title X program nationally, and the Centers for Disease Control. And the purpose of the QFP guidelines was basically to fill gaps that existed on a number of topics that were not covered in the MEC or the SPR. So in that version 1.0 of the QFP, it included contraceptive counseling, client-centered reproductive goals counseling, which used to be called back then reproductive life plan. Now we have a much better term for it, which is called reproductive goals counseling. It also had recommendations regarding pregnancy testing and options counseling, achieving pregnancy, basic infertility services, pre-pregnancy health, and then preventive screening for both women and men. And it was a really wonderful document that was fairly widely used in the family planning community after it was published. Well, it was time to have that updated, and so the Office of Population Affairs had a task force that was impaneled about 2 years ago, and then they finally published the updated Quality Family Planning Guidelines, what we refer to as QFP 2.0, and a number of resources that are available for using that. The new sections that are in the second version of the QFP include performance measures to track and improve quality of care. They were very briefly mentioned in version 1.0. Now they're in much more detail in this version. And also a very wonderful chapter on person-centered contraceptive care strategies. That is to say, how to do contraceptive counseling and pregnancy intention counseling. And in fact, Family Pack did a webinar on that very topic in October of 2022, done by Patty Cason and another speaker, and I've included the link for you there if you want to go back and have a look at that webinar that has to do with contraceptive counseling strategies. Really well done, and all of what is in that webinar is now reflected in the updated QFP guidelines. Okay. I'm trying to get to the next slide. Oh, there we go. I got to go back one. Okay, we're jumping all over the place. Sorry about that. Let's see if I can go backwards. I'm getting really close, I promise. Okay, here we are. All right, so this is the link to the actual publication of the Quality Family Planning Guidelines. It was published in the American Journal of Preventive Medicine in December of 2024. Note that this was not part of a collaboration with the CDC. This was done entirely with the Office of Population Affairs. But with this link, you'll be able to get the full article. Now, one of the things that's very helpful is an online QFP guide, and I've included the link for you, qfpguide.org. And this lists all of the different topics that are covered in the Quality Family Planning Guidelines. And you can click on these 10 different domains. It will go into much more detail about what's in the QFP. So, for example, fundamental issues of sexual and reproductive health care. In that first box, determining an individual's need and desire for services, person-centered contraceptive care, STI and HIV care, pregnancy testing and counseling, early pregnancy management, which is a new section, performance measures, and so on. So this as a job aid is just incredibly helpful because of the fact that it will give you lots of recommendations at your fingertips in terms of these quality family planning services. By the way, that was actually down for a short period of time, but now is up and available. So let's go to what you really came for, which was to hear more about what's new in the MEC, the medical eligibility criteria, and the selected practice recommendations. So fundamentally, the difference between these two documents is the fact that the medical eligibility criteria focuses on safety for contraceptive users, while the SPR focuses much more on efficacy, on how to use methods correctly in order to both maximize effectiveness and minimize side effects, for example. So this is the cover from the updated version of the medical eligibility criteria, published in Morbidity and Mortality Weekly Reports. Lots of different ways for you to actually get that. Oops. Second one that went by very quickly was the cover that had to do in that same issue of MMWR for the selected practice recommendations. Now, this is the template which is used for being able to look at the safety of various methods of contraception in people who have underlying medical problems. Again, originally that came from the World Health Organization, and we use it more or less the same way in the US CDC medical eligibility criteria. And remember, those 4 categories are category 1, which means that the method is considered to be safe for a person who has a particular condition, and they can use the method. Category 2 means that there may be some small problems associated with using that method for a given individual that are either proven or theoretical, but it's still reasonable for the person to use the method. However, the recommendation is that person may need a little bit more follow-up. And a good example of that might be a person who has type 2 diabetes, maybe is using metformin or insulin, that decides to use a hormonal method of contraception. One of the things we might have to do is to follow up that person a little more closely to make sure that the progestin part of their method is not having a negative impact on their blood sugar levels. But it's still perfectly reasonable for them to use the method. Now, what a 3 means is that now we're starting to get into this very close balance between the benefits of the method and the risks of the method. Anything that is considered to be a category 3 is still safer for that individual than actually becoming pregnant. But there could be significant problems of using the method, but they're usually outweighed by the benefits. So there are 2 different subsets of category 3. One is when there's information about the benefits and risks of that particular method, and they are explained in the medical eligibility criteria. There are other circumstances where there just aren't very many published studies, and so instead the CDC had to rely on expert opinion in deciding which particular category this should be in. But in general, we'd rather see people use category 1 or category 2 methods, but if they don't work or that's not acceptable to the client, then it's fine to use a category 3 method with appropriate follow-up. And then finally, the category 4 methods are one where the harms or the risks are substantially more than the benefits, and a person shouldn't use the method in her particular circumstance. An example of that might be a person diagnosed with breast cancer, treated for that within the last year or 2, and we try to stay away from hormonal methods so that it wouldn't have an effect on recurrences, for example. Okay, trying to get to the next one. There we go. Now, one of the things that's kind of underappreciated as it relates to the MEC is the fact that, remember the way that it works basically is that they look at various underlying medical conditions, as well as various categories of contraceptives. That's where those numbers come in. But one of the things that's contained in the document and in the app, by the way, is what is called clarifications, evidence, and comments. And I think that oftentimes clinicians don't look at that, and we really need to. So why they're a necessary element is that it gives you a lot more explanation when the numbers are just not enough. And I can tell you, having been on that expert panel, the 3 times that we've worked on these, we really spend a lot of time on the comments just because of the fact that sometimes there are nuances that are just not picked up in that number system. So it clarifies the numeric category if the number doesn't actually capture what the recommendation is. It summarizes the evidence for the recommendation if it exists. And as I said, when there's no evidence available, then that we use expert opinion, either from the WHO or from the US expert meetings. The comments provide additional rationale for the recommendation. And oftentimes references, additional detail that can be used during counseling and referrals. So I'm going to give you an example of how that works. So this is an updated version of what the US MEC says about headaches. So the first line is people who have headaches that are not migraines. So that might be tension headaches, cluster headaches, and so on. And you can see that every single method is considered to be MEC 1. The next 2 lines refer to people who have migraines without aura and with aura. And you can see that for everything except for the last column, which is combined hormonal contraception, oral contraceptives, patch and ring, that they're also considered to be 1. But for people who have migraine without aura, that's a 2. Migraine with aura, that's a 4. So they shouldn't use the method. But you'll notice the asterisk. The asterisk refers to what's contained in the clarification, evidence, and comment. And what that says for headaches is the classification depends on an accurate diagnosis of what kind of headache it is. So it gives you references, particularly in this case, the International Headache Society's classification of headache disorders, to help you as a clinician figure out, is this a migraine without aura, a migraine with aura, a tension headache, a cluster headache, a post-traumatic headache, and so on. And then the clarification goes on to say that if a person has new headaches or changes in their headaches once they start a method, you need to evaluate that, and that the classification system of the 1s, 2s, and 4s is for people who don't have stroke risk factors. And if they do have stroke risk factors, then you're going to use different judgment in making the decision about whether or not to use a hormonal method. So please pay attention to the comments, just because they may change your mind in terms of whether or not you're going to recommend a particular method to a patient. Now, let's talk more generically about what some of the changes that occurred in the medical eligibility criteria and selected practice recommendations this time around. And then that is that there's a real emphasis on person-centered counseling and method provision, emphasizing reproductive autonomy, people making their own decisions, how to go about the process of shared decision-making, and a real wonderful definition and explanation of what patient-centered approaches are to contraceptive decision-making. And by the way, the QFP 2.0 goes into even more detail on that particular topic. The language is much more gender inclusive. And then the third point is they really made a point of trying to tie into definitions that are used in, let's say, internal medicine, for example, for various kinds of conditions to make sure that they were doing the same thing. So when it comes to clotting disorders like thrombophilias or hematologic conditions or various subcategories of liver disease like cirrhosis or solid organ transplantation, those definitions were updated to make sure that they match the rest of the medical literature. Now, again, a real emphasis is on a person-centered approach to contraceptive counseling and decision-making, and that prioritizes what the patient's preferences are in terms of what they need in a method of contraception. And it really sort of explains the fact that not everyone is thinking about using the most effective method. We as clinicians tend to focus on efficacy, but many of our clients, that's not their priority. They're thinking about other things. Will my partner find out? What about side effects? How convenient is it? What's the cost? All those kinds of things might go into their decision about the method. How would they deal with the reality if the method didn't work and they had an unintended pregnancy? So with this approach, it expects the individual as being the main decision maker, not the clinician, and points out the fact that we have to respect the decision that a client might have about discontinuing a method, like I want my IUD or my implant out, or the decision not to use contraception at all, and just to be open to pregnancy, for example. Okay, so much more of that in this version. Now, the next thing that I want to mention before I hand things over to Jen is some of the resources that are available to us. And these are all available for free, developed by the Centers for Disease Control. So one is just going straight to the CDC website that has to do with the medical eligibility criteria and the selected practice recommendations. The URL is below, and not only can you get the documents of the MEC and the SPR, but quite a number of others as well. Okay, oops, I'm going to go back one because I missed something that I really want you to see. and unfortunately, our ability to share these slides is a little bit sluggish, but I'm getting there. Okay, one more. All right, good. That's what I wanted. And that is, I wanted to show you the picture of the app. So I know that most of you who are with us today have already downloaded the MEC SPR app, maybe in its earlier version. Hopefully you've also downloaded the new version as well. So you can see that over on the left side, that when you bring this up on your cell phone, for example, whether it's an Android phone, an iPhone, or a tablet and so on, you can see that you can look up the medical eligibility criteria classification by condition. In other words, high blood pressure, heart disease, history of deep vein thrombosis, being postpartum and breastfeeding, and so on. The second is by method. So you could look at what all the recommendations are for pills, patches, and rings, for progestin-only methods, and so on. Then there's a link to the selected practice recommendations, and then that bottom box is if you saved any information. Then the middle column will give you an example of the kinds of medical conditions for which the MEC has made recommendations based on age, anatomical abnormalities, which are primarily of the uterus, things like fibroids, people who are on anticonvulsant therapy, and so on down the line. And then you'll see over on the right side the fact that the app also covers the topics that are covered in the selected practice recommendations. So you can do that by chapters that have to do with specific methods. Copper IUDs, levonorgestrel IUDs, the ones that circled, is a new chapter that has to do with testosterone use for gender diverse people. And all of that is available on the app. So if you haven't downloaded it yet, it's available for free. Please do that. Just type in contraception in the App Store, and you'll be, in fact, better yet, CDC contraception, and then you'll be able to download it after that. You've already seen this. Other provider tools, which are on the CDC website, are MEC summary tables. I'll show you that in just a second. And then a whole bunch of new algorithms that are included. So when to start contraceptive methods, what to do if you're late in starting your method or you miss pills, management of people who have PID when they use an intrauterine device, management of bleeding irregularities while using contraception. All of those tables have been updated and are available both on the website and on the app. This is an example of the two-page summary charts that are available, and I love how they've done this because of the fact that they are color-coded. So if it's dark green, it's a 1. If it's light green, it's a 2. If it's sort of that light rose color, it's a 3. If it's a darker red, it's a 4. Okay, and this is page 1 of that summary of the MEC. And then there's a second page as well that includes all of the conditions that are covered in the medical eligibility criteria. So again, the way that a lot of people use that is to download it, print it on a color printer, put it in a binder or literally put it on bulletin boards in each exam room so that it's available to people. But if not, clinicians are very used to being able to use the app for the purpose of looking at those numbers. Okay, and one other thing to say, and I think Jen was actually responsible for getting this done, but now on the familypack.org website, you can also have access to the same resources from the CDC, the MEC, the SPR, the summary chart, and so on. If you have trouble getting into the CDC website, you're going to be able to access all of those on the familypack.org website as well. So with that, I'm going to stop for a little while, hand the microphone over to Jen, who is going to explain specifically what the updates were in the medical eligibility criteria and the SPR. And then after that, we're going to do a couple of cases.
Great. Thank you so much, Mike. So thank you for giving us that great history and overview of where we get all these guidelines from and where we can find all the provider tools. I'm going to jump in and do a little bit more of a deep dive into what are the changes that were made between the last version of the MEC and SPR and the new 2024 version. So I'm going to, there we go, advance the slide. So one of the major changes is that there were new disease categories that were added to the MEC. So one of those new disease categories was chronic kidney disease. And that includes a breakdown of specific situations that people could be in with chronic kidney disease, like having nephrotic syndrome or being on hemo or peritoneal dialysis. So that is now included in the current version of the MEC that wasn't there before. And then inclusion of new contraceptive methods since 2016. And so these new contraceptive methods include new formulations of combined pills or patches or vaginal rings, new formulation of our progestin-only pills, all 4 of the levonorgestrel IUDs, and the vaginal pH modulator. And I wanted to make a note so that everybody on this webinar remembers that Torla and Overa, all 4 levonorgestrel IUDs, and Phexxi are all FAM-packed benefits. So all of your clients can access these with their benefit package. So there's also been some changes in the way that the MEC is laid out. And so before, the MEC used to be laid out where all of the diseases and different contraceptive methods would fall into a specific category, either 1 or 2 or 3 or 4. And now we have some combined categories. So a MEC category 1/2. And that really speaks to the considerations that Mike had brought up a little bit earlier. So an example is MEC category 1/2 is now considered for chronic kidney disease for the contraceptive methods of the copper IUD, the levonorgestrel IUD, the implant, the barrier, norgestrel, and norethindrome progestin-only pills. And then for the category 3 and 4, you'll see our combined hormonal contraceptives, depot-medroxyprogesterone acetate, and then our drospirenone progestin-only pill with known hyperkalemia. And so if known hyperkalemia, and you're worried about worsening kalemia, that's where it really becomes a MEC4. And so they've done a really good job to have you think about what are the specific conditions that would push somebody to a 4 rather than a 3 when that category is there. So again, the importance of looking at those asterisks and those nuances when you're looking at the MEC. It also speaks to the more person-centered approach that that was taken in this version, because this really gives more decision-making ability and shared decision-making between the guidelines, the provider, and the client, who's the most important decision-maker in the end. All right. So there were also a few updated recommendations that were just tiny tweaks up and down, and they include everything on this list. For example, postpartum or post-abortion, including medication abortion, cirrhosis, liver tumors, solid organ transplant. I want you to take a second to just look at this list. And the most important thing about this list is to remember to take a look at your new guidelines before you think that you might know what category some of the contraceptive methods fall into. This is the importance of really downloading the new updated version on your phone, because in our heads we might remember, oh, that's a 1, and now actually it's a 2, and maybe we just want to talk to our client about that a little bit more. And so I just want you to have this list to remember that there were small tweaks to these categories, although nothing really large changed in these categories. So just to keep in mind, take a look before you prescribe something. Make sure that your memory is the same as where the guidelines are until we all get used to using all of the new guidelines. Okay, so there were also I wanted to point out some of the updated recommendations where there was less concern about safety or more concern about safety. So again, just getting these sort of in the back of your head. We're not going to remember all of these immediately, but just have it in the back of your head so you could say, oh, I remember Dr. Carlin said something about depot-medroxyprogesterone acetate. I can't remember if it was more concern or less concern. I'm going to look it up real quick. It's more concern, but we'll show you how and when right now. Okay, so less concern about safety. These are some of the disease categories that moved down in safety. So they were a 3 or a 4. So they were those categories that we really wanted to stop and talk to our clients about. If they were a 3, really explaining to them that we, had some concerns about risk. And if they were a 4, not using them with patients who had those disease categories. And they have moved to a 1 or a 2. So really less concern about safety. And those include our solid organ transplant and graft failure for IUD initiation. So any IUD initiation, copper or our levonorgestrel IUDs. Our systemic lupus, positive or unknown antibodies for our levonorgestrel IUD, our implants, and our progestin only pills have moved down to a 1 or 2. Decompensated cirrhosis has also moved down for our levonorgestrel IUDs, implants, and progestin only pills. And then our hepatocellular adenoma has also moved down for those 3 categories of methods choices. This is not such a big change because it just moved from a 2 to a 1. But our high risk for our HIV IUDs moved down to a 1, so no concern. Solid organ transplant, no graft failure IUDs, down to a 1. And then major surgery with prolonged immobilization for our levonorgestrel IUDs, implants, and progestin-only pills have moved down also to a 1. And all of this is based on new evidence and research that has really come out to support these moves. And then lastly, a previous DVT or PE and on anticoagulation therapy at a therapeutic dose for combined hormonal contraception has moved down from a absolutely not to a let's have a serious discussion with our client, from a 4 to a 3. So those are all the areas that we have less concern about safety. Now on the right, I'm going to talk a little bit about some areas that have more concern about safety. So as I gave you a little bit of a foregrounding about, our depot-medroxyprogesterone acetate has increased in risk from a 1 or 2 to a 3 or 4 for people with venous thromboembolus. So a previous one. our sickle cell disease for combined hormonal contraceptives and also for depot-medroxyprogesterone acetate, and then peripartum cardiomyopathy and impaired cardiac function has also moved from our 1 to 2 to 3 to 4. So really try to keep that in the back of your head for those categories, because that's a big change where you really want to talk to someone before initiating those. And then a 1 to a 2, a little bit more concern about safety, but still in the 1 to 2 range, is our conditions with increased risk of VTE, so your depot-medroxyprogesterone acetate. And then your postpartum, less than 10 minutes after delivery for IUDs, and post-abortion, first trimester Medicaid abortion with mifepristone for use for the abortion initiation for depot-medroxyprogesterone acetate. So not for a meso only post-abortion, but a post-abortion with MIFI and meso has moved from a 1 to a 2. So again, less really thinking about those first lines. The 3 to 4 to the 1 to 2 and the 1 to 2 to 3 to 4 is a little switch in your brain that needs to go off with these changes. I'm having the same problems with as Mike here. Hold on. Sorry. I can't. Okay. There we go. Okay. So the next larger change, like I mentioned before, and this now, our previous slide was, thinking about different disease categories. This is more about the method. So really here, what we're seeing is there's been a lot of data that's come out talking about increased risk of clotting with depot-medroxyprogesterone acetate. And so that is really why you're seeing all of these changes in these disease categories moving from a 1 to 2 to a 3. It's really about the data that's come out about depot-medroxyprogesterone acetate. And so when we're thinking about increased risk of clotting, we're thinking about people with a history of DVT and pulmonary embolus. We're thinking about people with thrombophilia. We're thinking about people with sickle cell disease, and then those other postpartum cardiomyopathy that I mentioned earlier. And then again, postpartum, we're thinking about people who are postpartum, so at increased risks of clotting, right? Because of still the increased estrogen in interaction with the depot-medroxyprogesterone acetate makes them at a higher risk of clotting disorders. So again, in your head, you just think, okay, I remember Dr. Carlin saying something about there being a higher risk, we think, about clotting with depot-medroxyprogesterone acetate. I'm going to just take a look in the MEC, but that was one of the big changes that came out in the MEC. And now I'm going to move on to the SPR and tell you about some of the changes there. All right. So the SPR was updated, as Mike was giving us a little bit of background about, in alignment with one another, because it's part of this compendium of resources that we have. And so those, the changes that were in the SPR really align with our changes in the MEC. And then there were some new recommendations. So testosterone, one of those new recommendations is that testosterone risk, use, and risk of pregnancy among transgender, gender diverse, and non-binary persons with a uterus is discussed in the SPR. In addition, the self-administration of depot-medroxyprogesterone acetate is discussed in the new SPR. And that aligns with, again, with the MEC and all of the recommendations in it. Also, there have been updated recommendations on how to manage bleeding irregularities during implant use. And then also pain management for IUD placement is a big change that was included in the SPR. And we actually have already had a detailed FAMPACT webinar on this topic on September 17th. So you can find that on our webinar section of the FAMPACT website about pain management for IUD placement. We will also be talking about paracervical blocks and pain management for IUD placements at our IUD placement workshop in October in Sacramento. So you could come meet us there and get a hands-on experience with that if that's what you're looking for. So just a heads up about that. All right, so the new SPR 2024 recommendations for testosterone use and risk of pregnancy is that for people who are using testosterone, we really need to be thinking about counseling that it may not prevent pregnancy, and then offer contraceptive counseling to those who are still at risk of pregnancy. So that's the main update included in the SPR about testosterone use. And then the main update about subcutaneous injectable contraception with our depot-medroxyprogesterone acetate subcutaneous version, which is 104 milligrams, is that it should be available for self-administration along with the intramuscular version to everybody who is coming in to hear about contraception. And I wanted to note that again, currently, the subcutaneous injection is only available by prescription from pharmacies. So you would need to write the prescription. The client could pick up the subcutaneous depot and they could either inject it themselves or they could come back to learn how to inject with you in your office. Sorry about the delay of this cursor. It's just taking. Okay, there we go. And then, like I mentioned, the medications for IUD placement and the paracervical block has been covered in previous FAMPACT webinars. And the main update to the SPR is that we should be talking about clients' pain that they may experience during IUD placement, and then ways of managing it that work for them. So different clients have various ways of already coping with pain and discomfort themselves. So finding out what those are and utilizing those, and then offering the tools that we have in our toolbox for helping with pain management in the clinic setting. This jumped. Just need to go back one. There we go. All right. And then it just needs to go back. Nicole, I'm not sure if you can control the back. I can't seem to get back.
Yes, let me do that for you right now. So
Thank you.
Let me know when to stop.
Back one, back one. Okay, perfect. Oh, okay, we did that, and then forward about testosterone, and then forward, and subcutaneous depot, covered by FAMPACT. Okay, next one, next slide. We were in the right place. Okay, here we go. So also the SPR included two different types of progesterone-only pills, so the better known as the O pill and SLIND, in their SPR about when to start a specific contraceptive method. So that was another breakout and change, is by including both of those options and talking about the additional contraceptive or backup that's needed, because those are different for the O pill and SLIND. So make sure when you're prescribing your progesterone-only pills to take a look at that provider, the provider tools to find when to start a specific contraceptive method. So now we're going to go.
One really quick comment before you go on. And,
Yes.
and the reason that those are highlighted is number one, because those methods were not available in the 2016 version. In other words, SLIND came out after 2016. O pill, of course, is the norgestrel progestin-only pill, which is available over the counter. And you can get that in a pharmacy, in a grocery store. It's available on Amazon. You can buy Opill now without a prescription. And the questions come up, is Opill covered by Family Pact and by Medi-Cal? The answer to that is yes. A little sort of convoluted in terms of how to actually access it, but they are covered. SLIN, the drospirenone progestin-only pill, is not either a Family Pact benefit or a Medi-Cal benefit. It has to do with the way that contracts are done with the drug company that makes drospirenone progestin-only pills, or SLIN, and how they work with the Medi-Cal pharmacy branch. So that was not a decision that was made by the Office of Family Planning not to cover SLIN. It has to do with how the pharmacy branch and the Department of Healthcare Services work. Okay, Jen, back to you.
Great. So now we're gonna see how much Mike was actually paying attention, and I'm gonna pose a case to you, Mike, and if you could tell me a little bit about what you know about. You can just advance the slide, Nicole, about chronic kidney disease. Great. So Mike, your case is we have a 28-year-old G2P2 with chronic kidney disease due to diabetic nephropathy, here and about to require hemodialysis. So they're here to see you. They want to initiate a contraceptive method, and they're trying to decide between an IUD or another hormonal method. So out of the copper IUD, the levonorgestrel IUD, the implant, depot-medroxyprogesterone acetate, the progestin-only pill, or any of our combined hormonal contraceptives, how would you go about talking to this client and answering this question? Next slide.
Okay, there we go. So as Jen mentioned, chronic kidney disease is one of the new disease states, which is included in the 2024 version of the MEC. It was not in earlier versions. The reason why, by the way, was because there weren't very many studies about the use of hormonal contraceptives in people with chronic kidney disease. But since 2016, there have been enough studies published to be able to come up with these recommendations. That's why it's brand new. Now, chronic kidney disease is not common in people of reproductive age, but it's not rare either. About 14% of adults have chronic kidney disease. It's somewhat more common in females than it is in males. And there is an increasing prevalence of chronic kidney disease with age. And that is to say about a third of people who are 65 or older, about 12% of adults between 45 and 64, which is kind of on the edge of the older age group for contraception, but 6% of adults between 18 and 44 have chronic kidney disease. And unfortunately, I'm not going to be able to advance. So Nicole, next slide, or next, just hit it once. There we go. Oh yeah, take remote control.
All right, go ahead, Mike. Go ahead, Mike. You can advance the slides now.
All right, good. Okay, hopefully. Oh, there we go. Okay. So the prevalence of chronic kidney disease among people who are reproductive age females is not entirely known, but the global estimate is somewhere from like 1 in 1,000 all the way up to 6%. About 100,000 women aged 18 to 54 in the US have end-stage kidney disease, of which about 13,000 were diagnosed in 2019. So again, it goes along with what I mentioned a moment ago. It's not common, but on the other hand, it's not rare for us to have to deal with this. Now, one of the things that we do know a fair amount about is problems related to pregnancy in people who have chronic kidney disease. And this is a study that was published in 2019 that looks at a variety of different obstetrical outcomes in people who have higher stages of chronic kidney disease, stage 3, 4, and 5 being much worse versions of chronic kidney disease. So you can see rather that when people have the higher stages of chronic kidney disease, they're more likely to have progression of their kidney disease, which leads to a need for them to use dialysis. They're more likely to develop hypertension, preeclampsia when they're pregnant and near term. Average birth weights are lower in people who have higher grades of chronic kidney disease, and they're substantially more likely to have preterm delivery. Look at those bottom two lines. And you can see that for people who have stage 3 or stage 4 or 5 chronic kidney disease, that quite a lot of them, not quite a majority, but almost, are at risk of having a delivery at under 34 weeks. So there are certainly risks of being pregnant, going to term with chronic kidney disease, and for people who don't want to take those pregnancy risks, we do need to we need to be clear about what their contraceptive options are. Okay, there we go. All right, now one of the things that the CDC really focused on is the fact that when people have chronic kidney disease, they're at an increased risk of clotting problems, both on the venous side and the arterial side. So this looks at the increased risk, particularly of venous thrombosis in people with severe chronic kidney disease, those who use dialysis, people who have a diagnosis of nephrotic syndrome. Oftentimes those overlap with each other. We know in addition to that risk of both venous and arterial thrombosis, there's an increased risk of bone fractures in people who have severe chronic kidney disease and if they use dialysis. We really don't have a whole lot of studies looking at hormonal contraceptive use in people who have a variety of those kidney conditions which lead to chronic kidney disease. But we know that among people who have chronic kidney disease, that our concern is that using combined hormonal contraceptives with estrogen, that is to say pill, patch, and ring, might increase their thrombosis risk on top of the already increased risk they have because of their kidney disease. And now there's concern that Depo-Provera might do the same thing. Not to the degree that the estrogen-containing methods do, but Depo can do that, okay? Not only increase the risk of deep vein thrombosis, pulmonary embolism, but we also know that because Depo reduces endogenous estrogen levels, that some people will lose some amount of bone mineral density as a result of using Depo. That's already happening in people with chronic kidney disease. So the concern is that that bone loss might be even worse in people who have chronic kidney disease and who use Depo. Okay, we went too far. Let me see if I can go back. If not, Danielle, there, no, we're still going too far. So here we go. Let me go back to now 3. I'm sorry, this is how, okay, there we go. That's what I was looking for. So now we have to go forward. And what this rather busy table is telling us basically is the effect of various progestins on clotting disorders, particularly the likelihood of venous thromboembolic events on the venous side. And this looks at a whole variety of case control and other comparative studies, which basically refer to where are those risks of clotting disorders, deep vein thrombosis, pulmonary embolism, the highest. So people who use DMPA, injectable depot-medroxyprogesterone acetate, NETA is norethindrone acetate, that's where the risks are highest. NPA is oral Provera, and then the 3 at the bottom are people who use levonorgestrel, contraceptive implants, norethindrone by itself, and the levonorgestrel IUD. And you can see with the 3 at the bottom, particularly with implants and with levonorgestrel IUDs, there is no increased risk of venous clotting in the way that we see that occurring with people who use Depo. And it's studies like these that led to all these upgrades of the classification in using Depo-Provera. Because historically we've said using Depo-Provera doesn't increase the likelihood of clotting disorders, but now we realize that there is some contribution, although it's not nearly as great as it is with estrogen. Now we know that in people who use combined hormonal contraceptives, that there clearly is an increased risk of thrombotic events. That happens with increasing age, particularly in the late 40s and into the 50s. People who are obese, who are smokers, particularly heavy smokers, people who have hypertension, thrombogenic mutations like factor V Leiden defect, lupus, and diabetes. So we already know from those studies coming out over, the last like 30 years or longer, that people who use pill patch ring have an increased risk of venous thrombotic events. We don't know much about other thrombotic conditions, and we really don't have a lot of evidence on patch or ring, some, but not a whole lot. And so we rely more so on the combined oral contraceptive data. Okay, oop, too far again. Let me see if I can go back one. Okay. All right, so that's what happens with combined hormonal methods. The next part has to do with progestin-only contraception. Okay, and that is to say we know with depot that there's an increased risk of venous thromboembolic events when people use depot postpartum or if they're diabetics. For other progestin-only contraceptives, there's limited evidence, and here we're talking about levonorgestrel IUDs, for example, or implants, that limited evidence shows that there's no increased risk of DVT pulmonary embolism, and we just don't have evidence on most other thrombogenic conditions. Okay, now there we go. All right, so here's some examples of medical conditions that are related to chronic kidney disease. Not the same, but related. And the reason I showed this is that the top panel is for people who have diabetes. The bottom panel is for people with hypertension. You can see all the way over on the right side that for combined hormonal contraception, for people who have more severe manifestations of disease, for example, diabetics with nephropathy, retinopathy, nervous system problems like neuropathy, people who have had diabetes for over 20 years, that combined hormonal contraceptives, because of this risk of both arterial and venous thrombosis, are either a 3 or a 4. And by the way, whether it is a 3 or a 4 depends on their severity of disease. Some people have less severe disease, other people have much more advanced disease. The more advanced disease, the more likely it is to be a 4. And by the way, I want to just mention one other thing we haven't talked about, and that's the difference between the I's and the C's. So one column for the I refers to initiating the method. The C part of the column refers to continuing the method. So if a person's already using method and they develop diabetes or they develop hypertension, that's how it relates. So we know with other medical conditions like diabetes, like hypertension, that there is an increased risk of thrombotic events. Okay, now what's new is in the DMPA column, because now you can see with there's more advanced conditions with either diabetes or with hypertension, that now those are 3s, and they used to be 2s in people who use DMPA. All right, so that in a moment will get us to the last slide that has to do with chronic kidney disease. There we go. Now, this is really taking a while. I may have to have Nicole advance that one for me. Okay, there we go. And so this is a summary of the 2024 MEC recommendations about chronic kidney disease. So basically what it's telling us is that for people who have nephrotic syndrome who are on hemodialysis, copper IUDs are 1s, levonorgestrel IUDs and implants are 2s, DMPAs are 3s because of the contribution to clotting effects. Progestin-only pills are mostly 2s, with the exception of drospirenone pills, that is to say SLIN, in a person who has known high potassium levels. And then in any of those kidney conditions, either starting or continuing the use of pill, patch, or ring is considered to be a 4. Okay. So just to finish up then on the case study that we're doing, is what methods can she use, given the fact that she's not on dialysis yet, but may need that at some point. Nicole, just advance it one more, please. And it'll have the answers to our case study. There we go. And that is for our 28-year-old G2P2 with chronic kidney disease, what's considered to be perfectly acceptable methods are copper IUDs, levonorgestrel IUDs, implants, and most progestin-only pills. Depot is considered to be a MEC 3. Drospirenone in a person who has high potassium levels is a 4, and pill, patch, ring are also considered to be 4s. Okay, so that's that case. Now I am going to read a case that Jen is going to answer, and it's about a person who has sickle cell disease. If we can get this going. All right.
Go ahead, Jen, you should be able to control it.
Okay, yeah. She's going to bring us the case, which I'll read, and then Jen is going to answer. There we go. So our case is a 35-year-old G3P1 with sickle cell disease, and she's homozygous, so she's SS sickle cell disease, not sickle trait, with a history of hospitalization for painful sickle crises. And she'd like to initiate a contraceptive method and is considering either an IUD or a hormonal method. So in a person with sickle cell disease who has a recent history of painful crises, which methods can be used? And here again, our alternatives are either type of IUD, implants, depot-progesterone pills, or combined hormonal contraceptives. So what would you say, Jen, about methods for this 35-year-old patient?
Great. Thank you, Mike. So when I'm thinking about this, I'm really thinking about both the pain crises and are there methods that will help or will hurt the previous pain crises, and then also the likelihood for someone with sickle cell to have more risk of stroke and clotting disorders. And so really, those are the two things that are in the back of my mind when I'm thinking about someone with sickle cell. And then the other issue is their anemia. Right? Like how are any of these methods going to affect their underlying low hemoglobin levels and anemia? And so the first thing I think about is, okay, the old MEC, which hasn't really changed on this, is that our copper IUD is a 2. Now, with the 2, again, you really need to think about what is the person's baseline anemia, because what a copper IUD will cause is a higher likelihood for increased blood loss in someone who is already anemic. And so, it really matters how bad that symptom is for that particular individual when you're thinking about using a copper IUD. So that's the first thing that we will think about. And then just for some background on sickle cell disease. As you mentioned, this is somebody with sickle cell disease, so they have actually 2 recessive traits, as opposed to sickle cell trait where you would only have 1. And it is a disorder of the beta globulin mutation. So it causes sickling of the red blood cells. And that sickling, that change in the shape of the red blood cells is what leads to venous stasis, blood being more hyperviscous, and those vaso-occlusive situations, in addition to tissue infarction and anemia. I already mentioned there's 2 different, there's homozygous sickle cell disease, and then there's the trait. And the prevalence in the United States is about 100,000 people, but it occurs differently in people with different origins, which oftentimes we name as Black or of African origin. So it's 1 in every 365 Black or African American births, and then 1 in every 16,300 Hispanic births. So it's just a little background. And as I mentioned earlier, individuals with sickle cell disease are an increased risk for both arterial and venous thrombosis. So a quarter of them will have a stroke by 45, which is quite impressive. And then 11% incidence of a venous thromboembolism by the age of 40. And that was from a single institution cohort study. So very, we need to be very concerned about venous thromboembolisms in our patients who present. Okay, the other thing that we know from a few meta-analyses is that the concern for a baseline risk of a VTE is actually higher in people with sickle cell disease than a pulmonary embolus. And both of those more than a deep venous thrombosis. All right. And the concern, there's a higher concern for recurrent VTEs. So if one of your clients has had a previous VTE and has sickle cell disease, that means they're at an even higher risk for a recurrent VTE. So here you see the odds ratio of in pregnant and postpartum people. for a venous thromboembolus of 33, and then of a DVT in pregnant people of 30. So again, we're talking about a third of people with sickle cell disease. So really important for us to keep that in mind. There's been a lot of evidence from meta-analyses about contraception in people with sickle cell disease. And so this is a summary slide of that. This is really great to look back on. So when we're thinking about stroke, there was a secondary analysis of a large prospective cohort of both occlusive and non-occlusive strokes. And there's an increased absolute risk of stroke for people with sickle cell disease. For venous thrombosis, there's 2 studies that we pull from that show that there's a low prevalence of thrombosis among hormonal contraceptive users with sickle cell disease, but no relative risk was examined. So really just looking at the overall prevalence. And then to note for pain, we talked about this in this case, this particular case showing that the person had had previous pain crises. So what do we know about contraception and pain crises? Well, we do know that combined oral contraception and progestin-only contraception did not increase the frequency of pain. And in fact, depot-medroxyprogesterone acetate may decrease risk of pain crises. I don't know why this, sorry, moved ahead. Okay, may decrease risk of pain crises and also dysmenorrhea. DMPA does decrease dysmenorrhea in other populations of people, not just with sickle cell disease. And so again, this really points to the fact, as we've talked about, DMPA increases our risk of venous thromboembolus, but it may decrease the risk of pain crises. So really talking to your client about what is it you're worried about, what is the likelihood of your disease course, and what may happen to you when you're thinking about contraceptives. And then osteopenia. There were 2 small studies that generally showed no increased risk of lower bone mineral density or osteopenia among those of hormonal contraceptive users. All right, so the next slide, there we go. So with those, with that evidence at hand, how did that get incorporated into the 2024 MEC updates? So what you will see here is that the combined hormonal contraception went from a 2 to a 4 for sickle cell disease. So really higher concern about those VTE and DVT risks. And then your DMPA also went from a 1 to a 2 or 3. Again, indicating that that superscript of the B is really moving towards a 3 if somebody has a higher risk of venous thromboembolus. So that would be someone who has had a previous VTE, as I mentioned, because the recurrent VTE makes you more likely to have more VTEs. And then you will see, like I mentioned at the beginning, that the copper IUD and the concern for anemia and causing higher rates of blood loss with a copper IUD did not change. So that's still at a 2. All right. So that, in summary, for this patient, you would really want to think about the levonorgestrel IUD, the implant, your progestin-only pills, and your copper IUD. If you had someone who really was concerned about their pain crises or and they wanted to decrease the likelihood of that, I would talk to them about DMPA and risk and balance those 2 side effects with them. And then really staying away from some of our estrogen-containing contraception is the update. So I'm going to summarize everything that we've talked about and give you some take-home points. So the CDC's US MEC and SPR are really excellent resources. They are available on our FAMPAC website. They will stay available on our FAMPAC website. They have been off and on available on the federal website. So if you are looking for these materials, go to your FAMPAC website and you'll be able to find them there, and we will keep them updated. Most people can safely use most methods. We really want to tailor our contraceptive counseling to be non-coercive, respect autonomy, and understand that different people have different goals and aims with their contraceptive, and it might not always align with ours as a provider. Most of the MEC category updates were related to the effect of DMPA on increasing risk for venous and arterial complications. The new disease categories that are included in the MEC were CKD, and most methods can be used in people with chronic kidney disease, except, again, those that increase the risk of venothromboembolus and arterial complications. So that's your depot-medroxyprogesterone acetate at a 3 and your combined hormonal contraceptions at a 4 because of the estrogen component. And that it can increase potassium levels. So our drospirenone progesterone-only pills with hyperkalemia is now a MEC 4. For our sickle cell disease, another new disease category, most methods can be used in people, except those that increase the risk, again, of venothromboembolus. If there's anything that you learned from this, that is the take home from this talk today. Again, depot-medroxyprogesterone acetate at a 2 or 3, and then your combined hormonal contraception at a MEC 4. And then we really want to think about talking to all of our clients about pain reduction in IUD placement, but also with all of our contraceptive methods, if we're placing if we're doing any other gyne procedures, or just talking to people about the side effects of any of their contraception. We really want to preemptively talk to people so we can help them work with strategies that will work for them. And then the other big announcement I wanted to say is that the Reproductive Health Hotline is a new service that is going to be offered out of UCSF. It is funded by the state of California, and it's a free, confidential, and nationwide on-demand hotline that can answer your questions in the moment when you're seeing all of your clients in clinic. You can pick up the phone and phone a friend. Experts in sexual and reproductive health will be picking up the calls live, and they will be able to answer any of your questions about the MEC and SPR, vaginitis, any question that you have, miscarriage management, abortion where legal. You can call 1-844-REPRO. We are live as of Monday. You can review our terms of service at reprohh.ucsf.edu and learn more about us. And you could also connect to us and get our materials by scanning this QR code. So I just wanted to let you know about this. It is sustainably funded for the next 5 years. So please give us a call, ask us. There's no dumb questions, and there's no question too complex. So please call us about anything that you have questions about regarding sexual and reproductive health, and we look forward to talking to you there.
Hey, Jen, one quick question about the hotline, and that is, can you type in a question, or does it have to be by telephone?
It has to be by telephone. And the other thing to note is we've taken a lot of care for this to be confidential and anonymous. So we do not collect a lot of data. If you are in the state of California, we will ask if you want to provide your information so we could keep you updated. But other than that, we will not be collecting any information. And that's also the reason why we don't accept texts at this time, because we wanted to provide a service that was comfortable for everybody to call in. We may at some point be able to do text, but right now it's just by phone. Great question.
Yeah.
All
right.
right.
Well,
And then I
was
will
gonna
move
say-
on. We just also, I had a few thanks, Mike, before we finish,
Sure,
to
please.
some of our CDC colleagues who were previously in the Division of Reproductive Health, who did all the research and the systematic reviews to create these incredible provider guidelines for us and to give us so much evidence in such an easy way to understand with these tables and spreadsheets. So I just wanted to give a shout out to Antoinette Nguyen and Kate Curtis. And then, of course, here's Mike's and my contact information for anyone to contact us. We're always happy to answer questions and be in touch. And then now we will go to questions from our participants. Thank you so much.
Okay, so Jen, one of the things I wanted to say about probably a third of the questions have to do with the very topic you just covered, and that is, what about the Division of Reproductive Health at the CDC, and are they going to be able to continue to update the MEC and the SPR, and what about additional like job aids coming from them? So, for example, some of the comments that were made is, I'm trying to
I'm sorry to interrupt. I just
download.
wanted to share. Oh, I'm sorry, Mike. I just want to share everyone. I know we're almost at time at 1:30, but I just want to let everyone know that both Mike and Jen are staying on for an extra 15 minutes to 1:45. So continue to send your questions in through the question box, and they'll try to get to as many of them as possible. And remember, this is also recorded, so if you have to leave at 1:30, still get your question in, and you can watch the answer at a later time, and you'll still get full CME credits. Thank you. Go ahead.
Okay, thank you. And Jen can also help me with this as need be. But many of the questions have to do with, I had trouble downloading the app because of the fact that it says that the guidelines are being updated, changed. Hang on, we'll get you the app sooner or later. Also, a couple of questions about the CDC in the past has come up with a wheel product that we could actually use with patients as a way of explaining to them about the various safety categories of the MEC, for example. Regrettably, it really is a moving target at this point. What we kind of hear, the best case scenario is that what's going on with the CDC and with the MEC and SPR app now is that the CDC is changing some of the language to be consistent with executive orders from the president, mostly have to do with gender and inclusiveness and so on. And that once that process is done with, then these job aids will be reposted, that they'll come back up again. We have no idea what they're going to look like. I don't think we have any sort of inside information about how much information is going to be deleted or how it's going to be changed. But at least what we've heard from the CDC is they recognize the importance of this work, and that once it goes through this scrubbing process, that it will be reposted. But one of the most important things that Jen just pointed out is it's not as if this is a complete blackout. You can get the original documents from the familypack.org website. The Society for Family Planning has these documents on their website. ACOG.org, American College of OBGYN, has them available without a password on their website. So there are a number of different places that you can go to be able to download these, at least in their original version, while we're waiting for the updates to happen. Okay, I wish I could tell you more, but that's about as much as we know about all the turmoil that's happening in the CDC about making sure that these guidelines are widely available to all of us. Jen, I've seen a couple of questions about depot. You're the big depot expert. I shouldn't say big, but you are the depot expert. So I'm going to ask you a couple of depot questions. Okay.
Sure.
So one is DMPA sub-Q given every 3 months? My one correction to that would be every 12 or 13 weeks. We think about it in weeks rather than months. So you might answer that in terms of what is the interval which is recommended for depot sub-Q in comparison to depot IM?
Yeah, it's the same. So every 12 weeks, but you have a grace period of 2 weeks. So like Mike said, Ideally, we counsel just because it's simple to set your calendar to provide a subcutaneous injection every 12 weeks. But if somebody misses their injection by 1 or 2 weeks, they don't need to use a backup method. They just give themselves an injection as soon as they remember and then restart the clock.
So
the other thing to note about subcutaneous depot is that the people who are candidates for subcutaneous depot are the same as IM candidates. The formulation itself doesn't change the contraindications or the side effects or who the good suitable candidates are. So, of course, when you're talking to your patients, it has to do with whether or not they're interested in giving themselves an injection and all the other person-centered benefits that come along with either a self-administered option, or there are some clients who like to come to our clinics and receive the injection for various reasons and don't want to give themselves an injection. So really tailoring the way that they're receiving the injection is what is most important, as opposed to what the formulations themselves do. Although there is less contraceptive liquid, so there's less liquid, and the needle is smaller in the subcutaneous formulation.
Right. So let me ask you one other question about depot, and I'll paraphrase a little bit of it, but read most of it. So, given what we've been talking about relative to the increased risk of deep vein thrombosis, pulmonary embolism from depot, if a blood pressure check isn't required of someone who's going to start depot, what if they have hypertension that they don't know about? And the question is, like, what if their blood pressure is really 160 over 100 and they don't know that? Given the new findings, basically, is there any difference in terms of how you would expect blood pressure screening and follow-up to be done in someone who's using either depot IM or depot subQ?
No, because the pathophysiology for the clotting is not due to blood pressure or increased blood pressure. So those things are not related. You really think about blood pressure with the estrogen component.
Right. Okay. Another one came in about depot subQ, and as I said,
you're getting all of these. I don't see them.
Are there any guidelines for patients giving themselves depot subQ at home?
There's no national guidelines, but the CTC, we could try to put this in the chat. The Clinician Training Center for Sexual and Reproductive Health has a toolkit, which I worked with a team to develop, that is guidelines about how to talk about it with clients, and has a ton of both provider tools and patient tools to be able to provide subcutaneous depot. So that is my go-to place, because it links all the evidence and it links all of the great materials that are out there, which include videos to share with clients that are both in English and Spanish, and then written materials in all sorts of languages to share with your clients.
We have so many depot questions. So let me ask you another one, although this is one that came up a lot at the Contraceptive Technology Conference in San Francisco a couple of months ago. And that is, do you have any information about how to counsel patients on the study that says that DMPA leads to benign brain tumors? So just a quick background on that. Yeah. There was a study done in Europe, I think it was in the Netherlands. It was a case control study, fairly large study, but remember that case control studies are not great from an epidemiologic point of view, which said that DMPA was associated with the development of a particular type of brain tumor, CNS tumor, which is called a meningioma. Now, the thing about meningiomas is that they don't actually happen in the parenchyma of the brain itself. It happens in the meninges, which are the covering of the brain, and they are benign. When that study came out, there was a lot of criticism of it, both for its methodology, which was not great, and the fact that in this subgroup of people who are using depot, the numbers weren't very high. in making this epidemiologic association between meningiomas and depot. So most of us have sort of discounted that relationship. Why you're seeing a lot about it on places like Facebook and on social media is because plaintiffs' lawyers are trying to find people who may have had that problem, and then they'll do product liability lawsuits about it. But at least in the medical community, we weren't very impressed by it. Jen,
I would agree.
what do you
Yeah,
add?
I would agree with that, Mike. And I would also point out, someone asked this in the questions earlier, and I wrote a little response that was shorter, but similar to what you just said. But also to note that if somebody has, the association was, again, a higher risk of having meningioma with prolonged use of DMPA. And there also was no suggestions about what to do if somebody had a meningioma and already, and then starting DMPA. And there was no clinical association with the meningiomas getting larger, but they also didn't have the power to even look at that. So the CDC, so someone had asked earlier, is there any CDC guidance on this? And there just isn't enough of an evidence base to suggest that it should be a higher risk category. So generally, this question has come up a bunch. And again, usually I share this information with the clients and then allow them to make a decision about the benefits that they're going to gain from DMPA and then the risks that they feel from a benign meningioma.
Great. Okay. Let's see. Let me see if I can find one.
I have one over here that's
okay, please.
So this is recalling the information question, Mike. So for someone who has a thrombotic risk, does it matter if the patient is taking one of the antithrombotic medications? What were the recommendations in the MEC about this?
Yeah, well, that was one of the things you mentioned. So presumably what's being referred to is a person who is on anticoagulant medication. So that could be heparin or one of the much, of course, newer ones like low molecular weight heparin and a variety of other medications which are intended to prevent either a DVT pulmonary embolism on the venous side or a heart attack or stroke on the arterial side. And one of the things that was addressed in the updated medical eligibility criteria is that if a person uses anticoagulant medications and they are in the therapeutic range, then you can use hormonal methods, including pill, patch, or ring in that person, because of the fact that they're taking anticoagulant medications, which presumably, given the fact that you've been following their laboratory studies and they seem to be effective as anticoagulants, that by adding estrogen to that equation, you're not going to now reinstate an increased risk of deep vein thrombosis, pulmonary embolism, or a stroke. So that's why I think, can't remember, we just talked about it, but if it's a 2 or a 3, but basically what it's saying is that as long as someone is in the therapeutic range of their anticoagulation, that they can use any of the hormonal methods. Jen, I'm going to ask you a question. I know you're looking something up, and you're more
I'm just answering that.
You're more qualified to answer this one as a family medicine doc than for me, because I've never prescribed these medications. So can you, and this, by the way, I'll tell you in advance, was not addressed at all in the MEC SPR. But can you speak to the contraceptive efficacy of the GLP-1 drugs like Ozempic, Wegovy, and so on? Do they have any effect on the efficacy of hormonal contraceptives? What do we tell people who are using those medications, let's say for weight loss or for type 2 diabetes? Do we know about any interactions with hormonal contraceptives?
So yes, and there is a chart that has the different GLP-1. I'm trying to look up the chart really quickly. I believe it was by rep. I will try to find it before the webinar ends. It just tells you which ones you may want to be concerned about if somebody is on them. But I don't always remember the different medications off the top of my head and which ones have a little bit of an interaction.
And do you remember, is that based primarily on like theoretical concerns about compromising contraceptive efficacy, or are there actually any studies that look at failure rates?
I think it's due to, I think some of the issues were due to delayed gastric emptying and the theoretical way that would affect.
Yeah, that totally makes sense. Yeah.
But, and I think it's also different, honestly, between the injectables and then the pills. So I can't answer it off the top of my head, but if you call the reproductive health hotline, I will be able to answer that for you. Just not in the middle of a webinar.
That's great. And then I think that Nicole Garcia put into the chat oh yeah, there it is. So Nicole, yeah, at 1:35, Nicole actually put in the link to reproductiveaccess.org about drug interactions with GLP-1 agonists.
That was the one I was looking for, Nicole.
Yeah,
thank you.
Wow.
That was exactly, yes. So that's my go-to chart that I've used because they summarize the evidence for us.
Yeah. All right. Well, there's one that I'll take, although of course Jen's, more than welcome to comment as well. Is aloe vera still considered to be a LARC, a long-acting reversible contraceptive? It was actually never considered to be a LARC. That the company that makes it sort of promoted it as being a long-acting reversible method, and given the fact that it's a one-year contraceptive, you can see why some people might actually consider it a LARC. But the original definition of long-acting reversible contraceptives, that is to say IUDs and implants, had to do with, and I love this term, that they are forgettable contraceptives. Once you've had your implant placed, once you've had the IUD placed, basically you can kind of forget about contraception unless you're having side effects until it's expired and you need to have it changed. That is absolutely not the case with aloe vera because of the fact that it is removable. People can remove it, in fact should remove it, to take it out and wash it every now and then. Some people actually take it out before they have intercourse because it kind of gets in the way, and then after intercourse is over, then they wash it and put it back in, which you're supposed to do within a couple of hours. So yes, it's a one-year contraceptive. Yes, it's a family pack benefit. Yes, it works really well as long as you use it according to instructions, but it's really not a forgettable contraceptive in the way that an IUD or an implant is a forgettable contraceptive. Jen, are you looking at questions? Anything you want to ask?
Well, so I can't see all the questions. All the questions on my side have been answered. So I think that Nicole is sending you different questions than me, but
oh, okay, all right.
I don't know if I can see yours somewhere. So if you have other questions that haven't been answered on my side, all of them we've either answered out loud or I've answered via the chat.
Okay. All right. I'm looking at one that says, should I then treat all obese patients with a BMI above 30 the same, regardless if they are morbidly obese? Well, weight issues are one of the categories which are listed as a chronic medical condition in the medical eligibility criteria. I don't think that they really changed very much. If anything, they might have changed a tiny bit for depot, maybe to go up one notch. But the way I think about this is was something that was published in an ACOG practice alert, a practice bulletin on the topic, maybe, I don't know, 5 or 6 years ago. And it was evidence-based. They have a really good way of kind of remembering things. And they basically said that if a person has a BMI of 35 or more, which is really being on the obese side, because technically obesity is a BMI of 30 or more. They said if a person has a BMI of 35 or more and their age is 35 or older, that combination in and of itself increases the risk of DVT pulmonary embolism substantially. So just being of that weight and being 38 or 40 or 42 already increases your risk of DVT pulmonary embolism. Then if you add the estrogen of pill patch ring on top of that, that would magnify the risk even more. So at least what that ACOG guideline says, and by the way, the same numbers are not used in the MEC, but I thought it was well documented in the ACOG guideline. That's a circumstance that you would at least consider a 3, if not a 4. The combination of both older age and a BMI of well over 35. And then if you add on top of that cigarette smoking or diabetes or other sorts of things which increase the risk of cardiovascular problems, particularly on the arterial side, you would be that much less likely to be willing to use an estrogen-containing method in that circumstance. And on the other hand, the flip side is that either the IUDs or implants are really good choices for people who are in that high BMI category, because we know that for people who are in a very high BMI category, that implants seem to work as well and depot seems to work as well. So, in those circumstances, we certainly have other alternatives rather than having to rely on an estrogen-containing method. All right, I'm just trying to see if there's anything else that we haven't covered. I think that actually does cover most of it. Plus, I think we're just about out of time anyway. We only have a few minutes left. So that being the case, I'm going to go back to Nicole and ask if you want to say any comments to wrap things up.
Yes, no, thank you so much. That was such an amazing webinar. Thank you. And thank you for going through all the questions. I know we have a lot more that we couldn't answer, but they were such good questions and the scenarios. So again, that will conclude our webinars. And please fill out the survey that will appear at the end when this webinar ends. Your feedback is extremely important and really helps guide the content and the type of webinar topics that we present. And again, the link to access your CME certificate, the recording, and the slide will be sent out in a follow-up email. So again, I want to thank you, Mike and Jen, the amazing tag team duo that did this presentations. And we hope you enjoyed it. And thank you for joining us. And we hope you enjoyed the rest of your week. Thank you so much.
Right.
Take care.
Okay.